It gives me a great pleasure to have South Africa, a country here. We are proud of their role at Lahai. Thank you very much. We appreciate so much. And we will start the session with Professor Hussam Hassan. He will tackle what is unique in hypertension management in Africa. Please, Hussam.
Thank you very much. Actually, I'm presenting a kind of project I worked with Dr. Natusi in it, hypertension management in Africa. Actually, this is a tough subject with many differences from what's known in the international guidelines. These are my disclosures. The agenda will start by discussing the burden of hypertension in Africa. Actually, hypertension is frequent in sub-Saharan Africa. According to the 2021 WHO report, the prevalence of hypertension varied from 25 to 48% in women and about 22 to 26% in men across the sub-Saharan countries. According to this data published in Lancet 2021, the number of adults with hypertension increased from 1990 to 2019 in sub-Saharan Africa, as you see here in the lower part. The international blood pressure cutoff for hypertension have not been validated in Black Africans, whatever it is European or American guidelines, and the definition of hypertension by office blood pressure or by home measurement or by ambulatory blood pressure, the cutoff numbers are not validated in Black Africans. Also, the comorbidities in Black Africans are also different. ECG in Black Africans have more sensitivity but less specificity to detect left ventricular hypertrophy, for example, than in Caucasian. And the ethnic specific ECG criteria can improve the detection of anatomic left ventricular hypertrophy, and actually echocardiography and CMR may provide more accurate assessment of left ventricular hypertrophy geometry and function. In addition, optimum methods to accurately estimate glomerular filtration rates in Black Africans are currently unresolved. Other risk factors can contribute to hypertension, and this is a systematic literature review with a total number of about 30,000 participants from 12 different African countries, showed that the expected association between alcohol use and hypertension is seen. Tobacco use and hypertension are not systematically linked across studies in sub-Saharan Africa. Also, socioeconomic factors such as urban residence, education, wealth, material status, and marital status, and having health insurance were also not systematically associated with the development of hypertension. And the available data highlighted the complexity of the situation in sub-Saharan Africa and the need for greater high-quality local studies and perspectives. The second point in the presentation, determinants, characteristics, and pathophysiology of hypertension in Africa. Hypertension in Africa showed a higher incidence of isolated systolic hypertension, nocturnal hypertension, resistant hypertension, occurring in young age and with more hypertension-mediated organ damage. Higher kidney disease, triple, higher heart failure and left ventricular hypertrophy, higher incidence of stroke, double or triple, and higher mortality. And the response to antihypertensive medications also differ among Black Africans than what is noted in the other population. What's unique in African people is they are used to take low sodium, high potassium diet in their environment. They used to live in hunting groups with a particular type of diet, which is low in sodium and high in potassium. They have some genetic background that favor sodium retention and also increased sodium transport with impaired excretion in the kidneys. So they are very sensitive to sodium overload. They are low renin hypertensive population with low aldosterone level. So this is present in about 80% of blacks compared to 50% in whites. So they are so sensitive hypertensives. So with modernization, increased visceral obesity, increased dietary sodium, and alcohol stress, excess calories, aging, diabetes, all of these lead to activation of RAS system and sympathetic nervous system, leading to hypertension easily in these patients who are used to be low sodium diet and are sensitive to sodium retention. So sodium and water retention occurs easily in these patients, leading to increased cardiovascular activity, vascular aging, peripheral resistance, and heart rate. So there are several factors contributing to hypertension. Some are genetic and some are environmental, affecting nitric oxide, prostacyclin, endothelial-derived hyperpolarizing factor, endothelin, asymmetric dimethyl arginine, and thromboxane, increasing the possibility of hypertension and possibility of having thrombotic events. Regarding awareness, treatment, and control of hypertension in Africa, these are also unique in Africa. We have low rates of awareness of hypertension, and awareness of hypertension in Africa is less than 65%. The predictors of awareness in this study that was conducted in South Africa were female gender, age more than 60, higher socioeconomic status, history of cardiovascular disease, non-immigrant status, literacy, and physical limitations. Again, this is applied for treatment and control. Low rates of treatment and control, and data from 49 countries in sub-Saharan Africa shows that the rates of treatment were more than 35% in both men and women in only 4 countries in Africa: Mauritius, Namibia, South Africa, and Seychelles. And blood pressure control rates were less than 10% in men and women in 12 countries, and reached more than 30% in men and women in only 1 country, which is Mauritius. In Egypt, the situation is a prevalence of 26% and awareness of 37%, and treatment 24%, and control rate is only 10%. There are some barriers to treatment and blood pressure control. Some are related to the healthcare system and physician-related barriers, like fragmented and poorly resourced healthcare systems, lack of trained healthcare professionals, limited access to appropriate hypertension treatment, and errors in medication prescription, such as dosing. And some are related to the patients, like unhealthy lifestyles, poor health-seeking behaviors, mistakes in taking medications, number of medications, and poor adherence due to forgottenness, multiple doses per day, and cost, lack of disease knowledge, and side effects. Actually, the initiatives have been proposed to improve this in Africa by shifting from physicians to nurse and village community healthcare professionals, and this needs access to medications and cost and better quality of care, and patients and healthcare professionals relations should be improved, and healthcare professionals and education should be done, and you have to deal with the stigma of being diseased. This feeling of stigma in African population of being diseased can be a strong barrier against taking medications. Simplifying treatment regimens is also important to improve adherence, such as taking single pill combinations. This, of course, improves the adherence of the patients, and we don't have randomized controlled trials in sub-Saharan Africa regarding single pill combinations compared to the free pill combinations. We have only Astral study in which 92% of the patients reported to have good compliance with single pill combination. Regarding the optimal management in hypertensive in African population, only 26% of sub-Saharan Africans have reported guidelines, and the current guidelines does not differentiate between African population and others for the management strategies for hypertension. Only the International Society of Hypertension guidelines, the latest ones that were endorsed by the Pan-African Society of Hypertension, recommended single pill combinations, including calcium channel blockers, in addition to either thiazide diuretics or ACE or ARBs. ARBs may be favorable for over ACE due to higher rates of angioedema with ACE inhibitors, but actually there is no comparative studies for this. This is just theoretical speculation. Monotherapy is still recommended in low-risk grade 1 hypertensive patients and frail patients and patients aged 80 or more. The no reports head-to-head comparison, as I said, between ACE and ARBs, combination treatment are preferable, and in patients not responding to dual combination therapy, triple combination with the three classes, RAS blockade, calcium channel blocker, and thiazide diuretics are recommended, and the recommendation are in favor of using thiazide-like diuretics like indapamide over the regular thiazides. We had only 4 recent trials in sub-Saharan Africa involving combination therapy, and this is a low number of studies. We need more and more studies regarding this to confirm a particular regimen for African population. Antihypertensive treatment need to be adopted according to the associated comorbidities, and only we have guidelines from South Africa and from Nigeria recommended in diabetics, ACE or ARBs, diuretics or calcium channel blockers; in nephropathy, ACE, ARBs or diuretics; in heart failure, ACE, ARBs, diuretics, aldosterone antagonists or beta blockers. What guidelines should say? The consensus statement that is proposed to recommend treatment for hypertensive patients, 10 points. Ideal annual screening for hypertension should be recommended in Black Africans of 18 years and old, and should be mandatory over 30. Lifestyle modifications to reduce blood pressure. Total recommended treat all those who are estimated cardiovascular risk of 10% or more at 10 years with systolic blood pressure more than 140 and diastolic more than 90 after trial of non-pharmacological therapy. All patients with systolic more than 160 and 95 diastolic should be treated irrespective of the risk. First-line pharmacological therapy should be single pill combination with calcium channel blocker in addition to either thiazide or RAS blockade. Randomized controlled trials based on differentiation between ACE and ARBs, which is better, as are not only identical in different patient population, and choice between the two classes will depend on the patient characteristics, availability, and cost. This is important to consider this in Africa. Chlorothalidone and indapamide are preferred over the regular thiazide diuretics for treatment of hypertension. Ideally, diagnosis of hypertensive to include out-of-office reading to confirm clinic readings. Failing that, ideally at least 2 sets of 3 clinic readings, mean of 2, carried out under standard conditions to diagnose hypertension. Routine investigations for antihypertensive patients should include urine analysis, blood chemistry, fasting glucose, hemoglobin A1C, lipid profile, and 12-lead ECG. Follow-up frequency should be 3 months, and after stabilization, 6 months. Statin use recommended in patients with abnormal lipid profiles, and use whatever drug available, as many as the ideal characteristics as possible. Use free combinations. If single pill combinations are not available, use thiazide diuretics. If thiazide-like diuretics are not available, use alternative to dihydropyridine calcium channel blockers. If not available, all tolerated. And finally, future research should be encouraged regarding research in population, research in behaviors, and clinical trials to have a sound scientific basis for recommendations for treatment of hypertension in Black Africans. And thank you very much.
Well, thank you very much, Professor Hassan. May I ask, we have the same treatment regimen for American African and African or Sub-Saharan African. If there is any difference in the outcome of treatment between the two populations in America and Sub-Saharan Africa?
Actually, there is difference because, as I told you, in Africa, we are affected by some environmental factors that are not present in Black Africans of African descent, Black people of African descent that are living in the United States. So the recommendations may differ because the circumstances and the environmental conditions in which these people are living are different. They are living in more modernized lifestyle, unlike the African population, different culture. All of this can affect the prevalence and the management of hypertension.
Any question?
Thank you, Dr. Hussam. You are addressing a very important healthcare system about the hypertension, which is a global major risk factor all over the world, including Africa and other parts of the world. The main issue in the management of hypertension is the early detection of hypertension.
Yes.
That the patient has to be aware, and the physicians also, the primary healthcare physicians.
Early intervention.
Absolutely, yes. You did not mention the guidelines which has been done by the Egyptian Society of Hypertension. We have done 2 guidelines in the last 10 years.
Actually,
addressing the situation in Egypt, which is an example of African country as well.
This was mentioned in one slide, mentioning the societies. There are some African societies with national guidelines, and Egypt is one of these societies. So the talk was regarding Africa as a whole. We didn't mention specifically the Egyptian guidelines. And actually, it was old guidelines.
Any comment or question? It's okay. Thank you very much, Professor.
Okay, thank you.
Now it's my pleasure to present Dr. Karen Flewa from South Africa. Is talking about, again, another major health problem worldwide, which is the heart failure challenges in our continent specifically.
Good afternoon. It's really a pleasure to be here. So how do you speak about heart failure in Africa in 12 minutes? I will try, and I will not speak fast. Yes, thank you. So what is the global burden of heart failure? It's an underdiagnosed condition. The current international classification of disease qualifies heart failure as an intermediate and not an underlying cause of death. Therefore, there's underreporting. Worldwide, it's estimated that about 67 million cases of prevalent cases of heart failure are recorded annually, and 85% of heart failure cases occur in low to middle income countries. The pattern of heart failure differs really globally. I just want to highlight, so if you look at Africa, we have a number of studies, but there is the Africa inter-CHF trial. You can see that hypertension contributed to 35%, ischemic heart disease or ischemia 20%, cardiomyopathy 14.2%, valve disease 11%, the CSIS acute heart failure registry, again hypertension 45%, and ischemic heart disease only 7.7%. If you look at the data from Middle East, inter-CHF data again on 1,000 patients, you see ischemic heart disease was 50% of the cases was the underlying cause contributing to heart failure. So a huge difference. Then followed by cardiomyopathy 18% and hypertension 10%. Valve disease 8%. This is a beautiful paper from Egypt, and the lead author is Magdi Abdelhamid. And you will know many of the co-authors on this paper. And this is from an interpretation or analysis from the Lancet burden of disease. They estimated the prevalence of heart failure in the Maniat region in 2019 to be 0.78% versus 0.71% globally. That means you have a higher prevalence. And they document a particularly high incidence of the heart failure with preserved ejection fraction risk factors and comorbidities in the region, including coronary heart disease, diabetes, obesity, hypertension, and chronic kidney disease. For instance, 14 to 16% of adults in the regions reportedly have diabetes, versus 7% in Europe. So if you compare Africa, Middle East, the risk factor is huge differences in the heart failure presentation. Male, 52%, 70% in Middle East. Mean age, almost the same. Preserved ejection fraction was higher in African cohort. Past myocardial infarction, I highlight that already, much higher in the Middle East. But all the other chronic conditions like chronic kidney disease, also higher in Middle East, and better access to healthcare in the Middle Eastern countries than if you take Africa or mainly sub-Saharan Africa. This year, our publication from the Global CHF was published. And I just want to show one slide on the paper. And the study had 23,000 participants, 40% were women, 60% were men, and they were followed up by 2.6 years. Women had a lower adjusted risk of mortality, despite adjusting for prognostic factors, and a pattern which was consistently observed across groups of countries, irrespective of economic status, geography, and LV, the systolic function level of the patients. What was also interesting that the treatment gap in many studies, women received to a lower percentage advanced heart failure medication. So that seemed to have narrowed. So women had altogether better access to healthcare when you compare to inter-CHF, which is encouraging. But patients recruited in Africa had significantly worse outcome, and we're working on another paper looking at that in more detail. Together with Ntobeko and Tusi, we published a paper on nutritional heart disease and cardiomyopathy in JACC at the beginning of last year, where we highlighted that there are particular pattern of cardiomyopathies, causes of heart failure in what is sort of called the tropical regions or countries with a high infectious disease burden. And this is peripartum cardiomyopathy as well. It's particularly common in the tropical belt. For instance, if you look at Japan and Denmark, the incidence is 1 in 20,000. If you look at Nigeria, is less than 1 in 1,000. Also in the Middle East, the data shows less than 1,000. India, 1 in 700. So there are certain conditions which are particularly common in tropical regions, which include Chagas disease in South America and endomyocardial fibrosis, which in the different regions really contributes to the burden of heart failure. I want to highlight the growing recognition of the environmental factors on the risk for coronary heart disease, hypertension, and subsequently heart failure. So this is a paper which was published very recently, and we looked at air pollution, noise pollution, exposure to metals, especially arsenic, cadmium, lead, other metals, on the cardiovascular health, cardiovascular risk factors and disease pattern with a focus on low to middle income countries. So who contributes to global carbon emission? So amongst the 20 lowest global contributors to carbon emission, 19 are in low income countries in sub-Saharan Africa. So those are the countries who contribute very little to this problem. So if you look at the mortality risk factor and its 2019 ranking, you can see the first one we all know is hypertension, then comes tobacco, then dietary risk factor, and then already air pollution. So on a global scale, air pollution is responsible for almost 20% of deaths related to cardiovascular disease, which includes heart failure, leading to an average reduction in life expectancy by 20 months, as figure which is closely to tobacco use, 22 months. And I think that many of our physicians, many people do not know that. We focus on tobacco, we focus to some extent, not very good on hypertension, but that air pollution, living in a city, living close to a road, which is very polluted, will have an impact on our direct life expectancy. So reducing air pollution is crucial for global cardiovascular health, particularly in low-income countries where the air pollution is highest. This slide shows that particle size matters exposure is high in many parts of the world. And the highest exposure occurs in Asia, Africa, and Middle East. And you can spot there Egypt, and it's unfortunately very high. If you look at the type of pollution we are exposed to, you can see in high-income countries, you have mainly ambient outdoor pollution or particle matter. From middle-income countries, you have an increased percentage of household air pollution, like solid fuel use. And low-income countries, it's actually a higher percentage due to household air pollution. And I cannot really go into it, but it's mainly indoor cooking and other parameters. There is really a lot of research has been done on the pathomechanism of particle-sized matter, how it activates endothelial dysfunction, increases vascular constriction, vascular inflammation, accelerated atherosclerosis, and it leads to activating of your platelets, increased coagulation, decreased fibrinolysis. So it's really an area which is, where our research has advanced in the last decade, but we haven't translated addressing it or patients who are particularly high risk, how to come up with recommendation to reduce their risk. But I'm sure if I would stand here in 10 years' time, that would change. So what can be learned about heart failure in Africa? There's a diverse pathology in precursors, diverse comorbidities. In many regions, heart failure is a diagnosis of adolescents in the breadwinner generation. So if someone is affected by heart failure, it has a major impact. Due to changes in pollution, climate change, lifestyle, processed food, there's an increase in obesity and hypertensive heart failure. And altogether, we have heard there's a lack of awareness of precursors of heart failure as hypertension. There's lack of awareness of hypertension, cardiovascular disease in peripartum women, and I talked about this before. And that can be prevented and tackled by awareness creation. Poor access to healthcare is leading to late diagnosis of the precursors of cardiovascular disease, perhaps not so much in Egypt, but in many parts of Africa, there are long distances to see a physician, to see a nurse, to get a test done. So the point of care testing facility would make a huge difference. And medication. We heard from the last speaker the issues with access to medication, the reasons for poor adherence. And we actually going to start a new study, the CESIS-2 heart failure study, in the middle of 2000, actually in 3 months. And I'm very delighted that many of the colleagues here at the conference and from Egypt altogether are interested in participating in the study, because it will also, this new study on finding out about what contributes to heart failure, how it's managed, what medication is accessible, and obviously about contributors and outcome will really inform how we better manage our patients. Better implementation, what is known, is always crucial, and we don't do it that well. But I was very happy to see another paper from Egypt on the current status of outpatient heart failure management in Egypt and recommendation for the future, which was published in the EAPC Heart Failure Journal very recently. I recommend reading it. So in conclusion, in many African regions, patients are dying prematurely from preventable causes. A large portion of healthcare resources are spent on complex interventions with limited resources used for prevention. Implementation of what is known, impacting physical activity, obesity, and subsequently hypertension and ischemic heart disease is probably the most important strategy worldwide. Use of already affordable medication, ACE inhibitor, beta blockers, mineralocorticoid receptors, SGLT2 inhibitors, and in optimal doses and rapid up titration based on the evidence we have the strong HF should be promoted, and jointly it can be done. Thank you.
Thank you, Dr. Karen, for this very informative coverage of the subject of important health problem in Africa. And you strongly connected or associated it to the environmental problem which is quite clear. Actually, we are the healthcare provider in this region. We are not giving much attention to this, which we should. In fact, about the environmental factor for the causation. There are some other causation also that, for instance, that we still have diseases which is not in Europe or in Japan, like rheumatic fever, for instance.
Yes.
Infection as well, but infection has improved quite a lot, but still there as well. And so we have to join forces actually to early detection of heart failure. It is a clinical syndrome, and so it has to be borne in mind for the physician to diagnose it. Thank you very much.
Yes, thank you. Thank you very much. I fully
Professor,
agree. Yes.
Sliwa, well, I have a question. Did you find any difference between women group and men group heart failure in Africa, in Black African?
Yes. I mean, all in Africa, but globally, the outcome of a woman who has heart failure when she's diagnosed and you look 5 years later is altogether better than the outcome in men. So this has been shown in global CHF and was also shown in other smaller trials previously. And even if women were undertreated, to some extent, they had a better outcome. So there is a substantial difference. But it's still a substantial mortality. So I don't want to give the impression.
Thank you.
And just a small comment. I'm Gabriel Nasser, professor of cardiovascular medicine, Sulzgani University. I'm asking you, what do you think that the climate change impact upon African continent? I'm very interested what you have said about the environment. Do you think we are going to suffer from climate changes, these effects on health more than other areas over the world?
There is actually a beautiful papers about it. I mean, it's not the topic of my talk, but I mean, there are stunning papers showing, one of the authors is Professor Simon Stewart, who showed that it's a change in the climate. So rapid changing is really not good for our cardiovascular health system. And in particular, if you have already risk factors or heart failure. So if it's suddenly very cold air condition here, you go outside and it's hot. This is not good. Or if one day is very hot and one day is very cold. And that we see increasingly with our global climate change. Yeah.
Thank you very much, Dr. Sliwa. And we'll move to the next speaker. The next speaker is one of the eminent speakers. We heard him yesterday talking about the management of hypertension and artificial intelligence. We are now going to hear from him the Imhotep study, genetic characterization in Africa with cardiomyopathy, Dr. Nutupiko Nutusi. I hope I am pronouncing the name in the right way.
Indeed, you are. Assalamu alaikum, and may I say how delighted I am to be part of your meeting. I am going to speak about a program of cardiovascular genetics that we hope will be an African-wide program. These are my disclosures that I'd like you to note. So Professor Sliwa has already made the point that cardiovascular disease is the second most commonest cause of mortality in sub-Saharan Africa. And that by the year 2030, it's predicted that NCDs, and in particular cardiovascular disease, will be the leading cause of mortality in the region. Heart failure is the dominant form of cardiovascular disease amongst Africans, and currently almost 80% of cardiovascular disease and heart failure specifically occurs in low and middle income countries. A review published more than 10 years ago, looking at over 20 hospitalized cohorts of Africans over a 60-year period, revealed that the commonest causes of heart failure amongst Africans were hypertension, cardiomyopathy, and rheumatic heart disease. And more recently, looking at acute cases of heart failure, a similar pattern was observed in the region from the thesis registry conducted in 11 countries. So if one takes a morphofunctional classification of cardiomyopathy, these are classified as hypertrophic, dilated, arrhythmogenic, restrictive, or unclassified. The unclassified cardiomyopathies include entities like left ventricular non-compaction or peripartum cardiomyopathy. And of course, all of these may be familial or genetic or idiopathic. Nearly 35 years ago now, the first series of publications on the genetics of heart muscle disease amongst Africans were led by a good friend of mine, Hanley Moolman-Smook, based at the University of Stellenbosch in Cape Town. And what they reported was the first candidate gene for hypertrophic cardiomyopathy, and over a 20-year period, discovered about 9 candidate genes that were found mostly in individuals of mixed ancestry, but also in white South Africans. And most of these were found in MYH7, the myosin heavy chain, 1 in troponin 2, and 2 in myosin binding protein C3, MYBPC3. And 6 of these clearly emerged as founder mutations that are now also reported amongst populations in the Netherlands. We then conducted a study using a 15-gene chip developed in the UK and used in the national health system with a yield of about 65 to 70% in people with idiopathic left ventricular hypertrophy for the diagnosis of HCM. And what we observed in Black South Africans who clearly don't carry the founder mutation was that the yield of genetic testing was far lower. And so we found mutations in less than 30% of individuals with a clear definition of HCM, where the same panel would have provided a yield of 60 to 70% in North America or Europe. And what this suggested to us was that either the known mutations for heart muscle disorders amongst Africans are different from what is reported in North America and Europe, or that mutations in the same genes may be different from what has been found in other parts of the world. But reassuringly, the spectrum of mortality was similar to what is found in other parts of the world. And this study shows the outcome in the cohort of patients with hypertrophic cardiomyopathy from Black Africans. You can see the 10 to 15-year mortality of around 70%, and that the major predictor of survival is the performance status, or your New York Heart Association functional class, and that patients with hypertrophic cardiomyopathy in South Africa have got similar outcomes to the general population. A second study looking at individuals with arrhythmogenic cardiomyopathy and using genetic testing, which is known to yield at least 50% of the diagnosis in the global north. Again, we observed in Cape Town that only 25% of people with a diagnosis of ARVC had positive genes, and all of these were in the plakophilin-2 mutation, which is a commonly reported gene that encodes cell-to-cell junction proteins. We also similarly found that the mortality and the age spectrum of the South African individuals with arrhythmogenic cardiomyopathy is similar to what has been reported in other parts of the world. We then looked at a cohort of patients with dilated cardiomyopathy and looked at a gene called phospholamban, which is known to be a common cause of familial dilated cardiomyopathy, and found again that in a group of 315 South Africans with different forms of heart muscle disease, there was only one family that carried a phospholamban mutation, suggesting that a commonly known mutation for dilated cardiomyopathy was in fact a rare cause of heart muscle disease amongst Black South Africans. And then finally, we looked at the clinical genetics of familial dilated cardiomyopathy amongst Black South Africans and found that these patients tended to be younger, and about 7% of them had relatives with peripartum cardiomyopathy. But reassuringly, the clinical family pedigrees were similar to what is reported in North American and European cohorts. So the vast majority, about 70%, have an autosomal dominant pattern of inheritance. Nearly 20% have a autosomal recessive pattern of inheritance, and about 10% with an X-linked recessive pattern of inheritance, which is similar to what you find in other parts of the world. So these studies, together with a whole host of other studies that I don't have time to review for you, suggested to us that amongst Africans, who we know are not only the oldest population in the world, but also a region with the greatest genetic variability, that maybe the underlying causes, genetic causes of cardiomyopathy are likely to be different. And so we embarked upon a program of scholarship that had three main goals in terms of the knowledge gaps we wanted to address. Firstly, to see if we could take a systemic approach to improved understanding of the genetic causes of heart muscle disease amongst Africans. Secondly, to study in an area abundant with infections what the contribution of myocarditis is to development of cardiomyopathy. And then thirdly, to try and understand at population level what the outcomes of heart muscle disease is amongst Africans. In undertaking this research, we aimed to have a combined program that also focuses on education, but also how we uplift and improve the standard of clinical care of patients with these conditions. And to do this through a registry program. And so how far have we gone? We have completed a pilot phase of the project where we recruited 1,000 patients from 4 sites in South Africa and 1 site in Mozambique. We've completed targeted whole exome sequencing in this population, and we've nearly completed trio studies and whole genome sequencing in those in whom we didn't identify mutations from the whole exome sequencing. And we are now planning to embark on a much larger study that will involve 28 countries and over 10,000 patients from sub-Saharan Africa. So what are some of the key observations from this program? The first is that unlike reports emerging from Europe and North America, where hypertrophic cardiomyopathy is by far the commonest cause of heart muscle disease, amongst Africans, dilated cardiomyopathy, as you can see, is the commonest cause of cardiomyopathy, accounting for over 72% of cases recruited into this pilot phase. And if you look at the etiological classification of the cases, you will see that about a third are familial, about a third are due to known secondary causes of cardiomyopathy, and about a third are truly idiopathic. And we think that the genetic contributions to both the idiopathic and familial cases are likely to be high. If you compare our cohort of patients with cardiomyopathy in the EMOTEP registry compared to reports emerging from Europe, you will see that the African patients tend to be younger, with the exception of those with hypertrophic cardiomyopathy, where the age is in the same range. And if we look at the age of disease onset by ethnicity, this is even more marked amongst Black Africans with cardiomyopathy who present at a very young age, with an intermediate age amongst those of mixed ancestry and those of white ancestry being white. And if you see what the spectrum of etiology is amongst the different ethnicities, you will note that, so if I just go back to the previous slide to orient you, that in purple is familial disease, in blue is idiopathic, and in green is secondary cardiomyopathy. So amongst Black Africans, the contribution of familial disease was low. Secondary causes accounted for the majority, and idiopathic for about a third. And contrast this to white patients in this registry, where familial disease accounted for over 50% of cases, with similar contributions from familial disease and secondary causes. Through this program, we've also been able to detect a number of novel mutations for cardiomyopathy amongst Black Africans. The first was the study of a family with clear arrhythmogenic cardiomyopathy with a high burden of myocardial fibrosis on MRI, high mortality in this family, as you can see from the pedigree, and most of those with a high burden of ventricular tachycardia, as you can see from the accompanying ECGs, and on endomyocardial biopsy, very high burden of fibrofatty changes, as you would expect in this condition. And using whole exome sequencing, we're able to identify cadherin-2 as a novel cause of arrhythmogenic cardiomyopathy. And of course, this made biological plausibility because cadherin-2 is a gap junction protein. And this gene as a cause of arrhythmogenic cardiomyopathy has now subsequently been reported in American patients from the Mayo Clinic, in a number of French families, and in China. We've also described another novel cause of cardiomyopathy in a family also with arrhythmogenic cardiomyopathy, with a much more benign phenotype by high burden of myocardial fibrosis, as demonstrated by the MRI images. And you can see from the spherogram at the bottom that the mutation is in a gene called POLG. And you doing functional studies using zebrafish models, we're able to duplicate the phenotype of cardiomyopathy in these fish with dilated hearts, slower heart rates, as well as impaired rates of blood flow. And this is now another novel cause of cardiomyopathy coming from this registry. A study co-led by Professor Karen Sliwa has looked at SNPs or single nucleotide polymorphisms and their association with the QT interval on ECG. And what we observed in this small study of patients with PPCM and genotyped for 12 SNPs, looking at the association of these SNPs with the QT interval on ECG, was that a single nucleotide polymorphism known as NOS1AP was associated with significantly longer QT interval, as well as impairment in LV systolic function, whereas a different SNP known as AKAP9 was associated with smaller left ventricular end diastolic function, but also impairment in systolic function. So to conclude, we are in the process of preparing a number of manuscripts to report on the genetic findings in this cohort, which are going to be quite unique. But what I've shown you is that heart failure is the dominant form of cardiovascular disease in hospitalized Africans. It has great social and economic relevance owing to not only its high prevalence and high mortality, but also its impact on young, economically active individuals. I've also shown you that cardiomyopathies are an important cause of heart failure amongst Africans, the second most common cause after hypertension. Yet the etiology, the genetic underpinnings, the natural history, as well as outcomes are poorly understood amongst Africans. Therefore, there is a strong and urgent need for mechanistic studies, population-based studies, improved diagnostics and access to evidence-based therapies, registries and randomized controlled trials from the region, as well as proliferation of centers of excellence for improved management of heart failure and specifically cardiomyopathies, and a greater focus on research for improving all concepts of heart failure amongst Africans. And our hope and vision is that the EMOTEP registry program will aim to address all of these gaps in knowledge. Shukran.
Thank you very much, Professor Metsi. We are a little bit short of time. Takes
just the one
short question.
Comment. First of all, I congratulate you for this registry program. I hope you're having more different data than the other areas in the world, because you already have the substrate, the different environment, nutritional deficiency, the parasitic infestation, the environmental factors also govern and modulate all genetic changes in this population. So I hope we can come to different data, different profile, and also you improve the healthcare system introduced to such population. Thank you.
Thank you very much for that comment. And my big hope is that as we roll out the EMOTEP program throughout the continent, there'll be a major contribution from Egypt.
May I ask a question? What about the L-carnitine deficiency in familial dilated cardiomyopathy? You didn't, there was no prevalence of doing this or screening this for familial cardiomyopathy?
So I haven't reported on that, but work led by my late colleague, Professor Bongani Mayosi, did look at mutations in L-carnitine and did not find a signal for dilated cardiomyopathy in Black Africans from Cape Town. And this is different from reports emerging from the US, where there was a signal of increased mutations amongst Black Africans with cardiomyopathy.
Thank you.
Thank you very much.
We'll come to the next speaker. I have the honor to introduce my dearest professor. This is Professor Fathi Maqladi. He is a professor of cardiovascular medicine, South Carolina University, the founder of the cardiology as a whole in Suez Canal area, as well as being the ex-vice president of the Suez Canal University, as well as he is the founder of one of the regions of cardiology in Egypt. I do have the honor to introduce my dear professor.
Thank you very much.
And his presentation is about the remaining burden of rheumatic heart disease in Africa.
Thank you, Dr. Gamila. And I have been assigned to talk about the remaining burden of rheumatic heart disease. As we all know, everybody in this theater knows that the rheumatic heart disease is still a nightmare of Africa. In fact, because it is not gone, it's still there, but almost forgotten. Forgotten, unfortunately, from the young generation, which did not pay an attention about the eradication and the elimination of rheumatic heart disease from Africa. Rheumatic heart disease continues to be a major health problem at the dawn of the new century in many parts of the world, including Egypt as well. Rheumatic heart disease and rheumatic fever is a social and a social alignment, increased incidence by poverty, substandard of living, and overcrowdedness in housing, and decreased incidence by improvement of the living standard. And so the presence of rheumatic heart disease and rheumatic fever is mainly as a social problem. WHO during the last 5 decades clearly documented that the control of rheumatic fever and rheumatic heart disease is not only cost-effective but inexpensive as well. World Heart Federation also had made the elimination of acute rheumatic fever and the control of rheumatic heart disease one of the 6 main goals in the strategic plan through 2015, but we have not succeeded in that so far. Let me share with you some facts about rheumatic heart disease. It's still prevalent, as just mentioned. It's a clinical challenge. Why it is a clinical challenge? It's a very subtle disease. It can pass unnoticed from the family, from the mother. It can pass unnoticed from the primary healthcare physician, the family physician as well. The child will have upper respiratory tract infection, will get some fever, will go to the general practitioner and give him antibiotics, and the antibiotics will improve. But consequently, it's not been diagnosed as acute rheumatic fever, and then the worst will happen with the damage of the valve. Unfortunately, the disease of the young population, who are the most economically active group and of the population. Rheumatic heart disease play a heavy economic burden on the healthcare system because of the medical management, the follow-up, the valve surgery, anticoagulant in the patient with atrial fibrillation, abstinence from work. The average age of mortality of the patient with rheumatic heart disease is 35 years, which is quite young. We do have now almost more than 40 million prevalent worldwide of rheumatic heart disease. About 100,000 heart failure, 320,000 mortality per year, and the prevalence of clinically silent rheumatic heart disease, 21 or 1,000. I would like to draw your attention about the clinically silent. Many of you have been faced by a pregnant woman come to the acute emergency with acute decompensated heart failure. She does not know that she has rheumatic heart disease. She does not know she has severe mitral stenosis before. And so it is a silent disease with a serious consequences. Complications, as we all know, very common. Atrial fibrillation is very common in rheumatic heart disease, and atrial fibrillation is linked with stroke. The patient with atrial fibrillation 5 times will develop stroke. And as you know also that stroke is the first cause of mortality and the first cause of disability. Heart failure is not uncommon in the patient with rheumatic heart disease. And also what's more serious, infective endocarditis. the infective endocarditis, the patient is miserable, and the physician who's treating him is miserable, and the family is miserable, because the prognosis is very bad in the infective endocarditis situation. This is some of the pictures which I'm sure all of you have been encountered in the past. We have some unresolved issues in rheumatic heart disease. And is any value of primary or secondary prophylaxis? This is a question. Value of screening of rheumatic heart disease, value of prophylaxis against infective endocarditis, and why we cannot eradicate rheumatic heart disease in Egypt. This is a very important question. We have 3 levels of the prevention: the primary prevention, the secondary prevention, and tertiary prevention. Actually, the target of the primary prevention is the most, because the family physician has to bear in mind that the symptom of this child or this young man could be a rheumatic heart disease. This is not there as well. And so, should we treat only children, should we treat all this age group? This is least costly, as a matter of fact. Treat only children who have the disease, the most cost-effective, and treatment based only on positive throat culture, that is more expensive as well. A meta-analysis of 13 penicillin trial. Penicillin is very cheap drug, found a 70%, more than 70% reduction in acute rheumatic fever. We have to have a coordination between primary prevention and secondary prophylaxis, especially medical and dental appointment, oral hygiene, making sure prescriptions are up to date, and making sure that the INR is at target. Support, educate, and encourage the patient and their family about this underlying problem. The rationale of primary prevention: pharyngitis is a common childhood illness. Almost 1/4 of the children will encounter upper respiratory tract infection, group A streptococcus bacteria. Acute rheumatic fever is thought to occur in 0.3 to 3% of individuals infected by group A streptococcal as an autoimmune response. The value of primary prevention has been known since 1950. That's a target point, that's a key point on the discovery of penicillin. Antibiotic treatment of gas infection reduced the risk of acute rheumatic fever by almost 70%. A strategy of secondary prevention, also the secondary prevention at the district hospital. Sorry. The district hospital and the people have to detect this early, and if the child or young man needs surgery, has to refer him. And the tertiary prevention of acute rheumatic fever, 3-4 weeks, benzazine penicillin is quite cheap as well, and is at hand. Heart failure management, if the patient have developed heart failure, which many of them will have, either treatment by drugs or by valve repair. Anticoagulation management is quite an important, and as has been shown recently by the Invectus study, that Marivan, which is a very cheap drug and very effective drug, is the most effective in rheumatic heart disease with atrial fibrillation and mitral stenosis. Arrhythmia management, endocarditis prevention, very important also, and prevention of pregnancy-related complications. What is the situation in Egypt? A few years ago, I have done some survey about the screening of rheumatic heart disease studies in Egypt. There is no national study. Dr. Ala Al-Amrawi has been fighting for the last 15 years to have a national study for the early detection of rheumatic heart disease in Egypt, but we have not achieved as far. And this is from 12 university medical schools, and we have a great number of studies. What we got from there, that the rheumatic heart disease prevalence ranges between about 6.8 per 1,000 in the community base. In the hospital, of course, has to be, the number is more because that's hospital referral hospital, and 16% has been found in this. Apart in this project Dr. Hamraoui has been trying to do, we have done the pilot study of the early detection of rheumatic heart disease in the school children in Ismailia, which is a governorate. We have examined total cases, 815 cases we have screened for this school children, rural and urban, women, girls and boys, and different age sector. And we found 32 cases from 815 cases, and the prevalence which we have found is only 0.04 in thousands, which is still an important one. There are 10 points to remember. Establish, continue secondary prophylaxis, quite an important. كان عندنا الصحة المدرسية has been vanished now, I don't know for what reason. Disease education and self-management support, regular clinical review, and echocardiogram. The echocardiogram plays a very important role nowadays in the detection of subclinical rheumatic heart disease. It's 10 times more sensitive than the clinical examination. And we had 2 big studies in Africa, also in Tanzania, as I remember, found that the echocardiography has 10-fold sensitivity of detecting early or latent rheumatic heart disease. Regular dental care, management of cardiac symptoms, and infective endocarditis as well. I would like to leave you with this recommendation: prevent rheumatic heart disease from occurring. Start from the beginning. We have to start by improving the health standard of the population, and also prevent existing coronary artery rheumatic heart disease. Diagnose rheumatic heart disease early before it starts causing symptoms and damaging the valve. Through repeated education session with the patient and the family, make sure that the patient understands what it's having. It's having is a very serious disease. No matter how severe it is, there are a good treatment for it. Further worsening can be missed with regular secondary prophylaxis, and having a valve replaced does not mean that the secondary prophylaxis can be stopped. And this injection of penicillin is quite important for those patients. Thank you.
Thank you very much, Professor Makladi, and the floor is open for a couple of questions, if any question. Well, I have a question for South Africa. Well, what is the rate of rheumatic valvular disease in your country? Professor Makladi had studied that in Egypt. In your country, what is the prevalence of?
So there have been a number of studies in the last 3 decades, and what they show are 2 patterns. The first is that there's a clear gradient between rural and urban areas, but also over time, the prevalence of rheumatic heart disease has continued to decline. And the latest data that informs our prevalence estimates comes from the Remedy program, which compared patients in rural and urban areas in South Africa and a number of other African countries. And the current estimates are now at less than 8 per 1,000 children. And the yield, as you will know, is greater with screening with echocardiography than clinical screening.
Very good. You are in the way to eradicate the rheumatic heart. Yeah.
So the principles remain exactly the same as have been articulated in the last talk. So a combination of a focus on public health measures to improve the standard of living, but also the use of penicillin for secondary prophylaxis. And in those diagnosed with symptomatic disease, being able to have a functional cardiac surgery program for valve replacement.
And a last question concerning Imhotep study you are doing. In Egypt here, we are marrying from the Nubian and Sudanese as well. Do you have the same in South Africa? It's not a political issue, but do you have the same when a black man marrying a white woman? Do you study in your Imhotep study this genetic predisposition?
Yes, so Professor Sliwa just reminded me how amazing it is that we are discussing the Imhotep study here in Egypt. And we take all comers, so people of African ancestry, people of mixed ancestry, as well as people of Caucasian backgrounds. And I presented the desegregated analysis by ethnicity. And similar to Egypt, we have a lot of intermarrying amongst South Africa. I recently was invited to give a lecture in the US on the state of cardiomyopathy on the continent. And I contrasted some of the findings in South Africa compared to findings in Egypt. And one of the main differences are the rates of consanguinity or intermarrying between relatives, where that's relatively low in South Africa, but higher here. And it has implications for some of the genetic findings as well.
You have Dr. Bongole, if I remember the name well, who was the dean of the medical school in Cape Town, who died a few years ago. He had very much interest in the eradication, working with us of rheumatic heart disease from Africa.
Yeah.
He was a very nice man.
Lovely man.
Absolutely. Yes, absolutely. I mean, Professor Moyusi, really, that was the focus of his research, rheumatic heart disease and genetic cardiomyopathy. You are absolutely right. And he actually initiated the Imhotep study, and then Professor Ntusi took over. You're right.
Well, by that, we come to the end of this fascinating session. Thank you. Thank you for coming. And thank you for all chairpersons. Thank you.